Welcome, everyone. This is fantastic. We have so many people that are here, and we thank you for your participation every month. Your presence increases, and we appreciate your participation and interest in the Third Thursday Trauma Talks. Go. So I am Mary McSwain, the Executive Director of the McSwain Trauma Education Project. So welcome to the Third Thursday Trauma Talks. We appreciate you being here. Tonight, Will Chapleau is presenting Is It That Simple? Will is a trustee of the McSwain Charitable Trust and the chairman of the McSwain Trauma Education Project. He's been a paramedic for 42 years, a trauma nurse for 33 years. I'm dating you here, I'm sorry.
Yes,
He served as a firefighter and eventually the chairman of Chicago Heights Fire Department since 1976. In 2012, he served as the director of performance improvement, managing trauma training programs for the American College of Surgeons and the Committee on Trauma. He was the chairman of the PHTLS, Hospital Trauma Life Support Executive Committee for almost 20 years, served on the boards of the National Association of EMTs, National Association of EMS Educators, and the Society of Trauma Nurses. He's written and edited 8 pre-hospital textbooks, published in 4 languages. He's taught and lectured in over 60 countries. He certainly comes here tonight with a wealth of pre-hospital and trauma experience. As stated, he's here tonight to present Is It That Simple? Madison Noble will be monitoring the chat for questions, and Steve will be monitoring for questions and answers as needed and at the end of the program. Again, thank you all so much for being here. We appreciate your participation. And so with that, I present Will Chapleau, please.
Hi, everybody. I want to thank everybody for joining us tonight. And let me get things wound up here. All right, so this is a lecture that I've done before, but I update it on a regular basis. And what I'm looking to do here is to look at our critical patients and what they really need from us and answer the question, or at least look at the question, but is it really that simple? And I hope by the end of the night, we'll have been able to provide some emphasis on that and go through some things. We're going to focus on the things that kill our trauma patients quickly and most frequently. And we'll use some of the studies that support the standards of care and what might be the standards of care in the future. We'll look at some treatments, some of which are common, and some of which you might not be aware of yet, but are coming down the pike that might be helpful to us. So without any further ado, we'll get to this. As I mentioned, we're hoping to take questions. Certainly people are monitoring what you're asking in the chat feature, and I hope to provide some space at the end. Now, I have a lot of material here. Particularly when I'm throwing up a PowerPoint to show you the research that I'm pulling data from. You'll see a lot of stuff. I'm not going to read those to you. It's just to show you in a sense of where I got this stuff from. So we'll try to keep it moving and express the points that are most important here. So here we go. Well, at least I thought we were going. Stand by here. It's not advancing. I thought I knew what I was doing, but apparently, there it is. Got it. All right. Let me know, anybody, if there's anything where you can't see something we can't hear. All right. The most frequent cause of preventable death is bleeding. And this has caused people to have another look at how we even do our assessments, putting bleeding out in front, particularly when we're looking on trauma patients. So we're going to look at what the current standard of care is for massive hemorrhage. What we're doing for them, what works, what doesn't work, and see what we can do going down in the future. Principles are find the bleeding. You've heard things like save every red blood cell, plug all the holes, do whatever you can, but We need to find what's bleeding and apply pressure to it in some way. Regardless of where the bleeding is or what methodology we're using, in some way, we're trying to apply pressure to that bleeding. Cover the wound with clean cloth, apply pressure by your hands, use tourniquets, wound packing. We're going to look at all of these today, some of which are maybe common or familiar to you, some of which maybe not so much. Wounds that lead to death frequently are, as we've seen, particularly from military experiences, but also from civilian experiences where there are explosions and cataclysmic type events where the extremities are torn significantly and exposing large blood vessels. These types of injuries can bleed quickly, and if they're not managed quickly, can lead to death. Again, here we talk about the use of tourniquets, direct pressure where we can, and if tourniquets are available, we can get them on there. They're going to secure these patients. Torso or junctional wounds, neck, shoulder, groin. These can be controlled by direct pressure and wound packing. I'm going to address wound packing today because I think this is a skill that's not difficult to teach, but I think a lot of people probably got through their training without anybody talking to them about wound packing. So we're going to talk about this, particularly with these types of injuries where tourniquets are not an option. We're going to have to make sure that pressure is applied adequately. And I'll ask you too, Madison and Steve and Mary, I have a tendency, particularly when I'm significantly caffeinated, to run a little quickly. So just give me a stop sign if you need to. Wounds that can lead to death. Now, this is the one that we're going to spend some time on today because it's one of those things we can't do a lot about. This is where the question, what's the best pre-hospital fluid, is often answered with the solution of diesel. When people have internal bleeding, there's not much we can do in the field except make sure that we've managed the patient overall, recognize the threat, and got them someplace where they can be repaired. But we're going to talk about this because there's a lot of attention being paid to this because of all the injuries that we're looking at. This has been one that eluded us as far as how to do field management. As it points out here, we can't fix that in the field currently, but maybe it's coming for it. Again, the treatments we use are tourniquets, wound packing, and hemostatic dressings. I want to look at a study that I'm actually doing a literature review on this for those of you that follow us in IPHMI know that we do monthly literature reviews. This is my study that I'm looking at this month. And this is some familiar names, like you can see Dr. Butler and John Holcomb in here. And what they basically did here is tourniquets have been around for a while now. And there are enough cases out there for us to start to get a better look at what kind of effect they've had. So here they did a study, and interestingly, they looked at everything that they had reported in 2019 into NEMSIS. Patients who had one tourniquet, two tourniquets, multiple tourniquets. They went to look at all of these patients that tourniquets were used that were loaded into the system and compared them against patients who could have had a tourniquet but did not. So they found 7,161 tourniquets were applied among 4,571,379 trauma activations. So there's a lot of patients here, which this is, when we're looking at retrospectives, they are certainly not double-blinded studies, but when we can get volume, this helps to give support for how effective things are. In these cases, a single tourniquet was used in 89%, 9.8% had two, three or more were used in almost 10% of the cases. The conclusion that they reached after looking at all these cases and comparing against the ones that did not get tourniquets were that they were associated with not just improved survivability, but lower scene time. Now, this to me is interesting because one of the things people are concerned about when we add a skill to something is that it adds time. But I think what we're seeing here is the struggle to control bleeding without the use of a tourniquet actually takes more time than getting a well-applied tourniquet into place. So results are indicating that a wider use of tourniquets might even give us a broader benefit in civilian pre-hospital settings. Again, just quickly to review the tourniquets that are acceptable. These, again, we're still currently using the Tactical Combat Casualty Care Committee recommendations on which tourniquets are effective. These shouldn't be any surprise to the audience. Again, by far the most popular and most often recommended is the CAT tourniquet. Easy to use, easy to self-apply even to some degree, and has been widely reported as being effective. Let me talk to you about common mistakes. Where often people talk about what about things that go wrong? Well, here's the things that go wrong. One, not using it or waiting too long to apply it when you've got long threatening bleeding. Not making the tourniquet tight enough to stop the bleeding. If it's still bleeding, it's not right. Not using a second tourniquet if needed. If the first tourniquet fails and they're still bleeding, get another one on it. And then periodically loosening. Now, dinosaurs like me, they've been paramedics for over 40 years, probably remember being told that we had to release the tourniquet every few minutes to recirculate to the extremity. Kind of bizarre, not good, actually could cause problems and certainly will cause lots of unnecessary bleeding. So doing that's a problem. Causes unacceptable blood loss, and also there's a chance for embolism. And again, removing the tourniquet is also cause for problems. So once you get it in place, those should stay on until you get to the hospital. People also often ask about improvised tourniquets. Again, those of us that are older, those of us that were in the Boy Scouts might remember being trained to make your own tourniquet. Well, these are generally not recommended because they're less effective. They're difficult to make without extensive practice. And here you could get into what that time feature would be as far as trying to assemble the materials to make an improvised tourniquet. It's going to take time you probably should not spend. Most improvised tourniquets are too thin and narrow, and poorly made, won't apply enough pressure, might increase the bleeding rather than decrease it. Hemostatic dressings have been, again, this was very useful in the military where applying direct pressure, while still possible, difficult to maintain, and certainly maintain a low profile in a live fire situation, it might be difficult. And these have proven very effective in even civilian settings over the last several years. This is the one I think that is interesting because I'm sure if we did a query, a lot of people in the audience would report that they didn't really receive training in wound packing. This is not rocket science. This is not that hard to do. In order to do wound packing, when you've got these wounds that are not in a place that you can apply a tourniquet, or even direct pressure is difficult because it's a cavity. First, remove the clothing, expose the bleeding site. If you can, remove or wipe away any excess blood, removing clots that are already formed, and then look into the wound to locate the source or what's causing the most active bleeding. That's your target for the packing that you're going to apply. Pack it using, if you have hemostatic dressing, certainly, plain gauze rolls or clean cloth. Pack the wound as deeply as you can, directing it to the bleeding site. Here's kind of a graphic that shows you it's not really a complex thing, and particularly in EMS personnel that have already been trained to do a lot of things, this should not be that complicated to do. And it probably, I think, is underutilized in situations where we've got bleeding in sites that are difficult to control with simple pressure, and tourniquets are not an option.
Hey, Will.
Yes.
This might be a good time to, for those that have been around for a while and everything, remember when we were talking about hemostatic agents, that there used to be a powder form of hemostatic agent that was out on the market initially, and that's no longer recommended in there for utilization in there.
The dressings that are in use now, and Steve, I think what you're addressing is that the material is impregnated into the dressing itself and not a powder that's loosely applied.
Right. Yeah. The powder that's loosely applied is no longer recommended and everything. The impregnated gauze is the one that is being recommended.
And I think we showed some of the names there earlier,
Yes.
but that's an important distinction. And thanks for bringing that up, Steve. Again, here, now this is something that's it actually came up in conversation the other day through some emails that were exchanged with us. And I had a medic in the field in Europe that was concerned about some of the TCCC recommendations that were saying, if you've got a failed chemical dressing on there, you can remove it to apply a fresh one. And the the medic was concerned about lay people doing this because they might not be as trained to handle that type of situation. So I think in that recommendation, we're talking about these types of dressings, hemostatics, and again, here's the list, that a trained medic that has a hemostatic dressing that's failed, it's okay for them to consider removing it to apply a fresh one, but we wouldn't advise that to people who are civilians that are trying to address the situation. Now here, I want to look at a situation that heretofore has been a problem for us. Internal injuries, the abdominal cavity. We know how, I mean, this goes back to the old movies where, if he was gut shot, well, he's a goner. It's when people are bleeding into their abdomen, as many of us have struggled with in our advanced age, your abdomen will grow to absorb whatever we stuff in there. And in the case of loose blood, it'll keep bleeding until the person expires. Interestingly, as you might imagine, the military is very concerned about this, and DARPA put a bunch of money into what can we do to manage internal bleeding so we can get them to a surgeon to save them. Some of you may have been aware of some devices where you injected small balled up dressings into the abdomen, which would absorb the blood and apply some pressure. It turned out to be a little problematic because sometimes they can't find all those little dressings, but they did apply some pressure. So we were learning that there might be an option. This money that was released came up with some solutions. Well, first one was Arsenal Medical came up with a product that is a kind of a self-expanding pure polyurethane foam, two separate elements. When they join after injected into the abdomen, form a foam that then fills the abdomen, fills the space and compresses the bleeding sites. That has been approved, and we'll talk about that in a second, has been approved for a clinical trial in a civilian population in Pennsylvania. We'll talk about that in a minute. The grant that they received allowed them to help to develop this product. And again, they're going to do a 40-patient clinical trial in Pennsylvania where they're going through the phase of getting the people loaded, getting people to the exception. So this is going to be a true double-blinded study, which will give us some valuable data on how effective these are. It's going to be in Pittsburgh, as you can see here. In 2019, it was approved. They're starting to get all the information together. As any of you that have done studies know, this is a pretty complicated process to make sure people can opt in and opt out and still be random enough to have maximal value. Another device came, they're actually, because this was a government thing, as you might expect, there were multiple solutions proposed. Here's another group, Critical Innovations. Their foam works a little differently. It's stimulated to expand by the heat in the body. And there's another one coming on, it's called Gel E, which is, their foam has been approved for other uses, is also working on trying to get this device as a possible solution for this problem. Now this, just to show you, because this one is furthest along, the clinical trials are set to begin soon. I wanted to show you this, because you can see here, they inject it into the abdomen where the bleeding is, and it forms this kind of it solidifies and compresses and protects the organs at the same time as it controls the bleeding. Now, hopefully, this is all going to work for you so you can see how it works.
The Arsenal foam technology has been engineered to treat life-threatening, non-compressible abdominal trauma. This product, shown here treating an acute liver injury, is injected as two liquid phases. Upon mixing, a chemical reaction is initiated, causing the material to expand throughout the abdominal cavity, making contact with sites of injury and creating a tamponade effect to stop bleeding. The product molds to the anatomy, allowing injured patients to be transported to surgical care where it can be removed.
Okay. So now, before I get into airway, Steve, Madison, do you guys want to take questions on bleeding before I move into another area, or should we keep going?
There's been a couple questions that we've answered them online, Will, and all they're fairly and all. So I would go ahead and continue on unless anybody has any direct questions for the do, just put them in the chat feature and we'll go ahead and address them at that time. If not, we'll hold them till the end and address them then.
All right, great. Again, there's a lot of material here, and I hope I'm not going too fast and you guys still find value in the conversation. Now, after bleeding, not breathing is the thing or not breathing adequately is the next thing that's going to kill your trauma patients. And for years, we were working our ways towards making sure that we had the opportunity to intubate. And that was the thing we wanted to do. We wanted to make sure all of our patients were intubated. We didn't consider anything else patent or positive. Now, what's been happening over time is that data has been pointing to basic things. You might remember studies over the last couple of decades that showed patients that were bagged with a simple oral airway and a bag valve mask had outcomes just as good, in some cases better, than patients who were intubated or intubation was attempted. In the meantime, lots of other devices have come in that are much simpler to insert. They're not the optimal block on separating the respiratory tract from the digestive tract to the point of supreme patency, but other options have been available which are safe and are giving us decent airways with much less time and complication. Here's a study where we looked at a systematic review of the literature about a variety of airway devices. And what they did here is they looked at comparative benefits and risks between the use of bag valve masks, supraglottic airways, and ETs. So they looked at everything. You know, what are you doing out there? What's working and what's not working? Are we gaining anything on the far extreme to the technical side, or is this simplest even better? So they looked at 99 studies, 630,000 plus patients, and they found few differences in primary outcomes between any of them. So again, this is what most of the data says. If you look at it, patients that are intubated, have SGAs, or are just simply oral airways with bags, there isn't a significant difference in outcomes. Whatever you can do to manage the airway, and this is what I used to tell my EMT students, my paramedics, they said, what's the best airway device? I said, the one that you're good at. And you should always this is the thing I'm best at. This is my backup, and know what you're going to do for your patients. And remember that time is important. We're talking about oxygen, and we're talking about making sure that it's there and that we protect the airway. So all those things are important. In their conclusion on this, they said, there's limited evidence to suggest differences between the outcomes of these devices in any pre-hospital airway management. So let's look at supraglottic. Now, there have been a lot of innovations in this, and I'm going to show you just some of the things that have come along, because it seems like the longer we look at this, somebody else has invented yet another, even more simple solution. These are easier and easier to teach people to use because they're placed above the vocal cords. They allow hands-free maintenance of the airway and spontaneous assisted ventilations. The recent advances are a new generation of LMAs. LMAs have been in use in surgery for years. Anesthesiologists don't want to intubate everybody either, so they use LMAs for a lot of procedures. Laryngeal tube airways, the Kings, Cobra, which has been around for a while, and iGel, which is a new one that might be the simplest of all. These are good because they can be placed without direct visualization. There's better cardiovascular stability because you're not obstructing while you're putting it in. And there's also minimal IOP and ICP changes. They can be used by all levels of pre-hospital care providers. You can teach first responders and citizens to put these things in there. That's simple. They provide little protection against aspiration. That's why we're going to keep coming back to that. You can make an argument for intubation is going to be the long-term solution for non-breathing patients. But when we're talking about what to do to get a person breathing now and then getting them to definitive care, I think the other devices are a good option. And again, might be a problem with full stomach patients because you're pushing it right down against the valves. Here's some of the devices, ProSeal and LMA Supremes. So you can see how they're constructed to fit just blindly inserting. They have, you can inflate the seals to give you a better seal once you get it in place. Inflate the cuffs, I should have said. Flexible AMBU and LMAs. Again, these are, again, a variation of the LMA devices with flexible devices to fit a variety of anatomies. These are good in head and neck surgery patients too, in some cases where you don't have the flexibility of full hyperextension to expose the airway to your efforts. Here's the elevated C-trachs. These, one is the capability of using cameras to help you place it. The other one is also you can intubate through the device, further using the camera to get the intubation tube in place. But you've got an immediate airway with the opportunity to get an endotracheal tube in after it's secured. Here's a simple king airway. Again, very easy to use. Inflate the cuffs. It secures it in place and protects the airway. Here's a side view of what this looks like when it's in place. Cobra Plus, on a newer end, distal end's got softened openings used for both spontaneous and controlled ventilation. So if the person's breathing, this helps to keep the airway clear, and it's also then a decent rescue airway. This is the one that's new. Not a lot of data on how it's used yet. It looks, you can see all over the internet, there's video on how this is inserted. It's relatively easy, like most airway devices. You can rotate it into the airway and seat it. Works fairly easily. Single use, it's cuffless, so you're not inflating any cuffs. It has an integral gastric channel, so it separates, as you can see on its design there. It's got a little channel to allow evacuation of gastric contents while keeping the airway open. Not sure how functional that is, but it's there. And there's a blocking ridge to secure the epiglottis. And all in all, the way it's designed provides like a molding feature. So this might turn out to be a decent airway. This now, and I'm moving much faster than my team thought I might be able to do. Am I going too fast? Anybody? I guess not. Let's look at obstructed airways. Now this I decided to talk about because I walked into my son's house and saw a device on his counter that I had seen on TV. And I thought, people are actually using these things. So let's look at this. LifeVac has created a device which you may have seen commercials on TV. If you haven't seen commercials on TV, they are marketing directly to EMS agencies, and people are buying these things on Amazon, at their grocery stores, and everywhere else. So let me show you a video about how this thing works.
Caring enough to see how LifeVac works. LifeVac is used when a person has an airway obstruction. Don't panic during a choking emergency. LifeVac is simple and easy to use. Simply place the mask on the person's face. Push the plunger. The air will vent out the side. While firmly holding mask in place, give it a swift tug. LifeVac has saved lives all around the world. It can save your loved one too. We appreciate you taking the time to learn how to use LifeVac.
Okay, so there's that. All right. Forgive me for that uninvited change. Let me get back to where I was. There we go. Nope, not from the start. Pay no attention to the man behind the curtain. Let's see here. All right, so this interested me for a couple of reasons. One is because it's already out there. If you go to their website, they say that they've had like 600 saves. Now, these are all self-reported. And one of the things that you get concerned about when you're looking at studies is that case studies or self-reported information means that I did it, it worked for me, there you go. I was talking to Peter Pons about this the other day, and he said, you might remind people, this is how we got the pneumatic anti-shock garment, because people use it, they said it worked, and we got it out there. That being said, I still used to like that. I kind of like that suit still, I don't know, but we'll talk about that on another day. But the point is that science requires the ability to evaluate the effectiveness of a procedure objectively and not subjectively. When you're doing case studies and self-reported results, that's subjective. Somebody's telling you, I think it helped me, or this did this, or this did that. That being said, I'm going to go through some studies now that have looked at this device and other devices like it to see if they are effective and whether or not they're safe. So let's get, I think some interesting things are going to come out here. This study here.
You click on play from current slide so that you get the full screen.
I'm sorry.
No, next one over. There you
Yes,
go.
I know this because I've used PowerPoints before. Okay, thank you. All right, so I'm looking at this one, and thanks, Steve, because now they can actually see. This study looked at suction-based airway clearance devices. Now, there's more than one. I showed you the LifeVac. There's another one out there that's more invasive. So you may see it referred to in the literature as a more invasive of the two. In this case, it's a mannequin randomized crossover trial. So this one, it's subjective, it's objective, not subjective, because they're measuring the effectiveness of these things on mannequins. So they create an obstruction, then they use the devices. So in this study, they found evidence that individuals using LifeVac were more successful in removing foreign bodies than people using abdominal thrusts. And they felt that further research, obviously, in clinical settings is still needed, because while a mannequin shows that if something is possible mechanically, it doesn't show us in real life situations that it's going to have an effect on patient outcomes. So that's promising at the very least. This study is phase 1 of what they call a global evaluation of suction-based airway clearance devices, a retrospective descriptive analysis. So in this study, they looked at people who, any individual who self-identified to manufacturers that they use one of these. So again, let's look at that, self-identified. So again, this is self-reporting. So the value is more subjective than objective. In these cases, though, they found that looking at this, they randomized through the trials, looking at the self-reported results, and there were 124 non-invasive, which is the LifeVac. And they concluded that non-invasive and minimally invasive ACDs are novel and potentially positive findings on these types of devices. Prospective evaluation, meaning independent manufacturers, is going to give us a better idea, because a lot of the stuff we get now comes from studies done by the manufacturers themselves. This study looked at, again, self-reporting folks. So healthcare workers, lay rescuers, that's another factor we're going to have to look at. If you are trained to use a device, does that give a significant difference in the effectiveness of the device if somebody who's never used it before? So can you, for instance, LifeVac is available on Amazon, grocery stores. Somebody buys this to save their kid's life if they choke. Are they going to be effective, or should they have been trained? So that's a question that we don't really know the answer to yet, except for self-reporters who say that they were able to do it successfully. Here's a systematic review on the effectiveness of anti-choke suction devices, trying to look at research gaps. And they looked at the literature again. They're minimally systematic, unbiased trials that look at the effectiveness of these devices. No studies were found that compared devices to the traditional techniques used to intervene foreign airways. So as a result, there's no high quality medical evidence. So this particular study looked at what was out there and said, because of the fact that everything we're seeing is provided by the manufacturer or they're self-reported, we don't have an unbiased, independent view that one is more effective than the other. That being said, one of the things that comes up is that if we looked at the data that supported abdominal thrusts or the Heimlich maneuver, these are mostly case reported studies too. So in a vacuum of having nothing else to do, anything that works part of the time, as long as it isn't harmful, is probably something that we should consider. So in this case, I guess the review of what this particular device or other devices like it are, is that it looks like it might be helpful. It doesn't appear to be harmful, but we need more information to see, first of all, if it's as effective and it changes outcomes. Secondly, are there training things that we need to address? Should we be training people to use these devices? And again, people will be reluctant to include that, for instance, in first aid training, unless we have more data to support it as a viable response. So I'm I'm talking to you about this tonight. It's new, it's relatively simple, it's out there, and you're gonna see this. I've talked to friends in our group that have already responded to houses where these things were used. You're gonna see these things in people's homes, and they are directly marketing. So your EMS agency may end up with this in your kit bag one of these days soon. So contrary to people's wishes, I can talk a lot faster than people expect. So I've gone through the material that we wanted, and as I hoped, we have a significant amount of time here to discuss some of the things that we talked about. So I'll take guidance from the gang here.
Yeah. Well, let's go back to, I want to go back on and touch on one thing that you mentioned earlier and everything. And it's when you're talking about airway. And I think it's one of the things that we fail to remember sometimes is you mentioned here to have a backup plan. And we can't express how important that is in there. We've seen instances sometimes, and unfortunately, we don't see it very often, but maybe the first airway of choice that they try is an RSI. Once you commit to an RSI, you've committed to provide an airway for that patient, period, in there, and what's your backup in there if that fails in there. And the second thing on there is the practicing in there. A lot of these airways, even though it sounds like they're simple to do, does take a lot of practice in there to continue to be proficient in there. So in your comments, always be good at whatever airway you use, be good at it. And that includes a practice of it and having a backup plan in there at all times, regardless of what the patient presents with.
Yep, absolutely. And I think I was talking to Mary before we got started, and one of the reasons we like this lecture is, and I don't know how many of my EMT students are out there. Many of them are getting to be almost as old as I am. But I always used to talk to them about, we've got a lot of tools in our toolbox, but the most important one is our head, our heart, and our hands. And a lot of the things that we can do for our patients are that simple. First of all, using your head to know what it is the patient's telling you they need. Number two, doing the simple things you can do with what you came in the room with, and not trying to create a situation for technology. I'm not against technology. I'm just saying a lot of the things we really need to do for people are quicker and simpler. And you can move on to further complexity once you've solved the simple and quick things. And knowing those things and having confidence to do it. You guys all know this. I'm looking through, you guys probably don't know I'm doing this, but I'm looking at y'all. I'm going through here, seeing all the people that are watching, and I see a couple more gray hairs out there. So you guys know this stuff, and your experience has taught you, confidence, knowing what you know, knowing what you don't know, approaching your patient with confidence, and not dawdling and screwing around. Get it done. And that's why I like doing this talk. And it's open to challenges from you guys. If I stepped on something or if I missed something, please come at us.
Well, here we have a comment in here, and again, it's one that we see quite often. Everything in one of your opening slides in there, we're talking about wound packing. In there, once you see, try to clean out the clots if possible, which kind of goes against some of the things that we've heard, in the past and everything. The purpose of removing these clots, when you can see them as a provider that's going to do wound packing and everything, is allows, if you're using a hemostatic agent, an impregnated gauze or anything, to have direct contact with that bleeding site, so that it can start to decrease the bleeding aspect of it and everything, where a clot in and by itself will prevent that from being able to have a direct contact with that bleeding site. So that's one of the reasons that you hear, remove the clot if possible, because it does impinge on the material being able to have a direct contact with the bleeding site. And again, we know that that's a little bit different than what we've heard in the past and everything, but this is what the studies have shown to be the most effective in there when you're doing wound packing.
That's actually great point, Steve. And I just looked at the comments and I saw a couple of you guys are concerned about that, because you're right. The way we were trained to do direct pressure, for instance, is never pull a dressing off, because you're going to pull the clots out. We're talking about, and this is an important distinction, your initial approach to a cavity wound. And in order for you to know what you're trying to manage, you need to wipe it clear, and get a look at what you're trying to do. Once you've identified it, pack it. So it's a little bit different. The other thing I told you tonight that is kind of contrary to what you may have learned is with the hemostatic dressings. TCCC has come out with recent guidance that well, it just fell out of my head, the type of dressing, but if it bleeds through, remove it to apply a new one. And the guidance now is probably not a good idea to tell lay people or untrained people to do that type of a move. But those of us that have been out there for a while, you guys are smart enough to handle that. If your tactical dressing fails, pull it, wipe it, do another one. So
I think another good point too in there. So anytime that you do wound packing, even whether you're using a hemostatic impregnated gauze or not, and everything, is that once you have that, you need to have maintain pressure on there if you're using hemostatic gauze for at least 3 minutes with direct pressure after you pack that. If it's non-hemostatic, you may need to hold on there for up to 10 minutes and then replace it with a pressure, replace that with a pressure dressing too, to maintain consistency to help decrease the bleeding sites.
I'd be interested to know how many of you have ever received training on wound packing. There's one. Let's see.
Yeah, it hasn't been. We haven't seen a lot of it. It was not in the national standard curriculum or educational standards, and it was just put in recently in there. So some of the people, if they did receive it, my guess is it was probably continued education as opposed to primary education.
And those of you that are trainers and educators, Steve and I have worked on this before with some of our friends, and figure out how do you teach wound packing. It's what we, in lieu of having an animal lab or something like that that you can use, or the expensive mannequins, we would go to the grocery store and buy we use big flank steaks, and we would cut a wound into it and then put IV tubing behind it to have fluid coming out, and we packed that rip that we put into the flank steak. And you can do that procedure that we just showed you on those PowerPoints and just make a nice cut, create the bleed in there, and just show how you can. And the weird thing is, if you've embedded that IV tubing in there with fluid coming out of it, you can apply enough pressure to stop the bleed, even in that synthesized environment. But just to give you that practice at doing that motion and doing it, and give people that confidence. So when they get that wound that is not in a place that they can get easily to apply pressure or a tourniquet, they have an alternative and say, yeah, I've done this. I can do this. It's not really hard, but
We see one of the comments was made, somebody that they just taught their high school EMT course, and they used foam. They sliced open foam and had them practice packing wounds with foam, which is a good idea. Again, trying to use some of the material that you have around, and foam has some density that's equal to some of the skin and muscle that we have in there. When we made the video for the Stop the Bleed campaign, we actually used a pork shoulder in there. If you ever seen that, that's actually as a pork shoulder underneath those pant legs that we used in there. And also you can get quite creative in the way that you go about there. But again, trying to make it as realistic as possible, and they're allowing people to see what it is. Because another thing that comes into play there, especially if you're using a roll of Curlex or cling, is how you hold it to where you can pack it in there. Most all of them you see has a Z fold to them now that allows you to easily hold it in one hand and pack it with the other without dropping it. Usually if you're using a Curlex or cling like that, you'll drop it and it goes rolling across the floor in there while you're trying to pack.
Yeah, you can do it with a roll too, but it's something you have to practice. And thank you for reminding me about the pork shoulder, Steve. That was beautiful. I think we cried a little bit after we saw that video. It was so perfect.
Yeah. Okay, good. Again, we're looking, if anybody has anything else that would like us to address here this evening, please feel free to put it in the chat and everything. Another thing that I'd like to do is just a comment on Will by himself. In the opening comments and everything, one of the things that we probably need to say about Will is Will's also the founding member of the International Pre-Hospital Medicine Institute. He is one of the founding members and the chair of that also, as well as his work with the McSwain Trauma Foundation and the McSwain Trauma Education Program. That's the little symbol that you saw on his vest there, and also on some of the slides. Okay, here's one. Someone would like to know.
Occlusives.
Just we got a couple ones here. Occlusive dressings. Okay, well, the stand-all in there. My guess is, comment on occlusive dressing. If we're talking about occlusive dressing and a chest injury, is what I would assume that's what they're talking about. And the criteria, is it 4 sides or 3 sides?
Yes. We've been talking about that a lot because while there isn't a lot of data that points to one or the other, it's one of those things. It's just like anecdotally, common sense. People feel like having a place where the pressures can be relieved if necessary is important. But I think anybody would argue if you put an occlusive dressing on there and it was well sealed, that's all they're worried about. I don't know that anybody can prove 3 versus 4. I would just go occlusive dressing is the right answer. Steve, is that consistent with what we've been looking at?
Right. Yeah, I think if you're going to lean, I think that what if there's any shift, it's probably towards the 3-sided one for the ability to vent. And most all of them, you'll see there's some commercially available vented seals too that you can get for the chest in there. And that seems to be the lean anyway. But I don't think that there's, again, as you indicated, there's a significant difference in between them. Again, if you've got a patient that you've got a chest wound in, you've got an occlusive dressing on there, and they start deteriorating, lift that corner, see if that helps out. In the worst case scenario, you'll seal it back up.
Yeah. I used to teach my students to burp their dressings if they had to. But whatever you got to do, it's like paying attention to your patient's the most important thing. Whatever you do is going to have an action, good, bad, or different. You need to watch them. And if you're seeing trouble, even in a 3-sided dressing, it could clot over the opening, and you might have to pull it off if that's there. That being said, I think the incidence is fairly low. There's more concern about not doing the occlusive dressing than not doing it. And wouldn't you agree with that, Steve? That's pretty much.
Yeah. We got a couple more comments here, and here's another good one that I think is important too. And the question is, should the second tourniquet go above or below the first one? Okay.
Always above.
Yeah, it goes above. It goes above. That's one of the reasons when you see a lot of the information, everything about doing putting a tourniquet, they say to go, the first tourniquet should go, 2 to 3, 3 to 4 inches or so above the wound. So in case you have to put on another, a second tourniquet, you have room. Some of the people, they'll put it on high, which is not wrong. It's just, it gives you some limitations on being able to put another second tourniquet on there. But ideally it should go above the first tourniquet that you put on.
Agree, totally agree. That's to make sure you leave yourself some space. Now, the next comment
again, it's having a backup plan.
Yep. Always think about what's your next. What's your next?
Yep. Okay, so here's another good one. What's a good BLS airway? Well,
all of them.
All of it. Yeah, again, I think it's the one that works within your system and everything. But again, we sometimes fail to remember that we start at the basics and work, start at the easiest or the most available. Don't forget that, there's the oral airway, the nasal pharyngeal airway, and the bag mask, which works very, very well in there. But it gets a bad rap sometimes because people aren't efficient with it. Okay. But again, then you move from there, you go into some of the single or lumen or multi-lumen airways that in there. I think all of them have pros and cons associated with them. You need to address this basically probably with your services medical director and get them involved in helping making that selection there that also fits within your scope of practice within the area that you with the service that you work with too. But again, there are a lot of good ones out there. And again, I think it's what you feel the most comfortable with and what your medical director's approval in there too.
Yeah, keep in mind, if you remember early in the presentation on airways, I showed you that study that said there was no statistical difference between bag valve mask ventilation, and people that were intubated across the entire spectrum. So getting an oral, being good at the very basic things, whether you're putting a nasal trumpet, you used to call them nasal trumpets, or the nasopharyngeal airways, or an oropharyngeal, whatever you got, whatever you can get in, whatever's there, and then do your basics, making sure the mask is sealed appropriately is just as good as far as the patient is concerned at maintaining the airway and ventilating that patient. So they're all good. That being said, I believe, and you guys correct me if I'm wrong, that these new combi tubes and stuff are available for EMTs and first responders as well. They're being included in a lot of basic protocols. Am I wrong on that? Anybody?
Well, again, you just need, it depends on the state and and the area that you're in. You have to look at what your scope of practice is within your licensure in there, and your services protocols in there.
So it goes back to what's the right one, the one you've got, the one you're good at, and whatever your backup is.
Yeah, there's not one that's showing any high incidences more than the other one.
That's pretty significant. And like I said, again, shout out to all the gray hairs I see out there that are playing with us tonight. But when we went to our Orange Book EMT schools in the 70s, all we had was nasal air, nasopharyngeals, oropharyngeals, and a bag valve, and the mouth screws. Remember those horrible devices? But we had those very basic things, and it turns out years later they're as effective as everything else. What it comes down to, what's the most effective? Doing it right. Having the skill, making sure you know what you're doing, and doing it right, and paying attention to what your patient's telling you. If you're bagging your patient and they're still blue, you ain't doing it right. Something else is going wrong. There's an obstruction. You don't have a seal. The airway's not in place. Just make sure that you're paying attention to what your patient. One of the things I frequently talk to my students about is your patients talk to you even when they can't. The fact that they can't, they're speaking to you. Go back to the beginning, make your assessment, and everything. It's not a laundry list. If anything fails, you have to resolve it and keep moving through those things. Oh, so what tourniquet would you recommend for the average citizen? The cats are great. I think that's the safest and most easily available. They're not cheap, but
if you get it, but to make sure that you get a real cat, there's a lot of knockoffs out there.
Good point.
I know you need to make sure that what you're getting is the true cat, and the cat is the one that has the most scientific evidence behind it and everything. And it is simple to use and everything. But again, be cautious of $3 tourniquets.
I like Wes here. He said, keep practicing what we have. Yes, Wes, absolutely. But at the same time, one of the reasons we do these talks and I show you stuff that's kind of new is to challenge everybody to look at it and pay attention and be ready for it. Certainly expose yourself to new things, but don't be dependent on new things. Be able to deal with, because say that you've got, what's in your rig, and then you're with the kids on Boy Scout camp and something bad goes up, or you're at fishing or at a baseball game, these corpus injuries where people get slammed in the chest, all this stuff that can happen when you're not near your kit bag. The most basic, which sometimes again is your head, your heart, and your hands, you have to be able to apply what's there. Not always what you know, but what's there. So definitely practice with what you have, but always be thinking about, well, what if? Okay, this is what I do with this. But what if I don't have it? What am I going to do? And it sounds intimidating, but it's not that scary because it comes back to the basic things we know. What we know works, we know that they need for us. We can do it. That's what we've been doing our whole lives.
Yay.
All right, now you guys got to challenge us a little more. I know you're out there. There's over 60. We're over 70. We're down to 68. So we're losing it.
Well, what I did want to do, let me take an opportunity for those of you that are still here again next month, which will be February, the third Thursday Trauma Talk. Dr. Jeff Solomon will be our speaker, and the topic is yet to be determined. But if you keep an active eye on the MTEP website, you'll see it come up after we get a decision from Dr. Solomon. Dr. Solomon is a surgeon out of Arizona who started life as a paramedic in Las Vegas, and has been a member of the American College of Surgeons for quite some time, and has set up a few trauma centers and all. And he's a very, very knowledgeable and likable guy in there. So, and that'll be the third Thursday of February, which I think is like, I have to stop and think. It'll
The third
be,
Thursday.
yeah, the third Thursday, whatever that date is.
Yeah, it'll be
That's
good.
probably-
And we'd like you guys to get in the habit and share it with others that if it's the third Thursday and it's 8 p.m. Central Time, we're here. We're always going to be here. We're always going to have something else to talk about. Visit us on the website, the Norman McSwain's website. And,
Looks like the 16th of February is the third Thursday
there you go.
in there. Okay, so here we go. We got another question here. And I like this. How do you deal with bleeding with bariatric? This is probably where you're gonna, if you're talking about bleeding from a bariatric in places that they're a little bit larger than the normal individual, you're probably going to be doing a lot more packing in there, and it's going to take some very, very deep pressure in order to help sustain that. So again, not a whole lot different other than you're going to put more pressure in there, and you're probably going to use more packing material in that. But again, it should not change your practice a whole lot. They're wonderful candidates and everything for hemostatic dressings in there.
That's a good point. Yeah, hemostatics can help because bariatric patients can be a challenge for tourniquets too.
Yes.
They give, depending on what show you've watched on A&E, the size of people can vary, up to 1,000 pounds. And to try to get most of the conventional tourniquets around somebody that weighs 1,000 pounds, it might not even fit. So packing and other things are going to be where you end up. It's sort of like these things are on a trajectory. It's like on one end, the tourniquet, might be the extreme solution. If it doesn't, you're back in direct pressure land. And if you can't get it on there and hold it, then you're going to pack it. And then back to the simplest, which is direct pressure. So in all of these situations, the most complex to the simplest, you start with the simplest solution. And if it's not, then you ratchet it up to another level. And when the person, like a bariatric patient, presents to you, it's going to be a more basic response in a lot of situations because the devices just are not engineered for those situations.
Okay, good. Well, it looks like we're getting down to the last couple of minutes here and everything. Again, thank you for your talk tonight, your everything, and I thank everyone that attended this in here. It's been a wonderful time for those of you that, again, took your time this evening to participate in this. Remember, keep track of our website on a regular basis. We'll keep things posted in there. We'll keep things posted in there. And as you said, the next third Thursday Trauma Talk will be February 16th, and it'll be Dr. Jeff Solomon will be the speaker there. And with that, everyone, you can thank you for your time. And now it's time to probably go enjoy it looks like the bar was open in there.
Cheers, everybody. And again, Steve just said what I like to end all my lectures with. It's just thank you for your time. We can talk into a vacuum or a void, and none of this stuff works, and we don't have a place to play unless you guys are paying attention and giving us more feedback. And again, continue to challenge us, whether it's here or the books and courses that Steve and I are working on. All this stuff only has value if we're meeting a need and we're able to work with what you guys are doing on the street. So keep challenging us, keep listening, and we'll look for you here the third Thursday of every month. Mary?
Yeah. And if there's specific topics and everything that you'd like to hear about and everything, please send us an email. We've got a pretty vast, we've got a pretty good well of information or knowledgeable individuals that we can tap into we can probably address what it is that your concerns would be. Also look out for some conferences. We also are doing some upcoming conferences. And again, those will be posted on the website. We finished up a conference in December in Cancun. terrible to have to do a conference in Cancun in December.
Oh,
But we took the challenge in there, and we have a couple more coming up this in the near future here. So keep on the website. Somebody asked about how do you get a certificate? We don't issue certificates of continuing education in there because of all the different states and all. But what you should do is address this with your state EMS agency, and we can give you verification of having attended this program by your login here. And so that's the easiest way for you to go about getting your continuing education credits for this, is contact through your local state EMS office. Okay. With that, we'll say good evening, Mary. Do you have anything? You're muted. There you go.
No, nothing further other than thank you, Will, and thank you, Steve, for moderating, and just to everyone that's here, thank you for being here. We wouldn't be here if y'all weren't here. So let us know what you need. Let us know what you want. We are here for you. That's what MTEP is about. We want to know what you want to. We want to know what you want to know.
One other thing I'll add is, I know we have some friends in Europe that were concerned that this thing starts at what would have been 3 a.m. for them. So tomorrow I will have a link that you can get back to us. If somebody wants to see what we talked about tonight, we can provide the link so that they can see this at a later time. Particularly, we're trying to keep this international network going with all our friends. So we'll make sure that that's available to them too. And again, like everybody has said, keep pushing us. You know, whatever we can do, whatever we think we're doing is only important if you think it has value. So keep pushing us.
Yep.
So how you get your verification, send an email message through the contact us on the website for MTEP, and we'll get your verification of your attendance for this. So just send an email through the contact us on the website, and we'll get you taken care of.
Yep.
Thank you,
Good
everyone.
evening.